Hey, good morning, scholars. It's, let's see, what day is it now? It's going to be the 30th. 30th. 30 days has September. So Friday will be April Fool's Day. Friday will be April Fool's Day. So say, hey, thanks very much for those assignments, for the quiz questions. The questions that you wrote. True, false, multiple choice, and briefly explain questions. Those were great. I just want to remind you, though, that it's best if you put the answers with them. I forgot to have you do that. I've been trying to figure out some of the answers to some of them the last couple days, and I am scratching my head, but that's okay. I've got dandruff, so scratching my head is good. But anyway, thanks for those. You're going to get a similar assignment for Friday regarding yesterday's material and today's material. So you'll be meeting again as teams on Friday to construct 4 more true-false, 4 more multiple choice, and another 4-point briefly explained short answer question. Again, I looked at some of the questions, and most of them are pretty darn good. But again, take a look at the past quizzes to see how those questions look, and look at yours relative. Look at those that you've written in the past relative to those quizzes, and then as you maybe try to write even a little bit better this time, the questions, you'll have something else to go by. I don't think I'll have them graded and back to you by Friday. So I can, that's just where that is. But thanks so much for doing that, and they're looking good. So I encourage you to find a time when you can get together on Friday and do this next assignment, which will be similar. I'll also put that on the old course web there for you. Okay? Hey, well let's get into this material here. We hopefully finished on Monday talking about the main joints of the shoulder complex. I'm going to call it the shoulder complex. Technically, the shoulder is the glenohumeral joint. The glenohumeral joint is technically the shoulder, but the shoulder complex, all the component parts, would also include that acromioclavicular joint, the acromioclavicular joint, and the sternoclavicular joint. And it's also going to include another articulation, well, sort of an articulation. It's not called a joint, but it's going to include where the scapula articulates, or where the scapula runs over the back of the thorax, over those ribs in the back, the scapula and the thorax. We're going to talk about that a little bit today. It's often ignored when we talk about the shoulder, and boy, that scapula, especially how it articulates with those ribs, is so important to allow appropriate shoulder motion. It's really an unsung area again. So it's one of my favorites. All right, so today we're going to look at the movements of the glenohumeral joint. Take a look at scapulothoracic rhythm, what that means, and what types of movements occur at the scapula that work together with those movements that occur at the glenohumeral joint. Might be a couple other things we'll mention too. So movements at the glenohumeral joint. So standing in anatomical position, we can flex the shoulder in the sagittal plane. We can extend the shoulder in the sagittal plane. We can abduct in the frontal plane. We can adduct in the frontal plane. From the anatomical position, we can medially rotate the humerus. That would be bringing your thumbs from the outside across the front into the middle. And we can externally rotate, bringing your thumbs back from the palm forward, from a palm backward position to a palm forward position, anatomical position. So we had flexion, extension, abduction, adduction, and this rotation that will occur in that transverse plane. Then we're going to have two other movements, a pair of movements that are kind of unique to the shoulder. And for those to occur, we first have to abduct our shoulders to 90 degrees. So from anatomical position, abduct your shoulders to 90 degrees, and then bring your arms together in the front, and that's called horizontal flexion. Horizontal flexion. Some folks might call it horizontal adduction. Horizontal adduction. What plane is that working in? What plane is that working in? That's working in the transverse plane. That's working in the transverse plane. So if we have horizontal adduction, we also have horizontal abduction. So that's 4 pairs of movements now. The last one that occurs at the glenohumeral joint, I couldn't hear myself there, is circumduction. Circumduction. So those are the 9 movements that occur at the glenohumeral joint. We're going to take a look at the muscles that cause those movements in just a minute here. The scapulothoracic movements are thinking how the scapula moves on the back, and this is my right scapula facing anteriorly, looking at how this scapula moves on the thorax. Well, let's see. If I can protract my scapula, meaning I can have the scapula slide around the front, protract. That happens if I punch and then try to extend that punch. Punch, try to extend that punch. So that's protracting the scapula. Sometimes we retract the scapula. We bring the scapula back closer to the spine. So retract, bringing it closer to the spine. Protract, bringing it farther away from the spine, are 1 pair of movements. Another pair of movements would be elevation. If we work both traps or in both levator scapulas at the same time, we can elevate the scapula. And then we can also depress the scapula. We can pull the scapula down. Pull the scapula down. And that's mainly the lower traps. Mainly the lower traps would pull that scapula down. So those are the main movements that occur at the scapula. Elevation and depression, protraction and retraction. Okay, I hope that makes sense. Okay, on this next page, here's a picture of my great-grandfather. No, it's not. It's not. But it kind of does look like him, I have to admit. And you can see he was a defined young man with nice hair. But let's take a look now at the muscles that move the shoulder. The muscles that move the shoulder. So we've kind of got them grouped here, and there's some strange names in how they're grouped. But when you understand the terms, I think these will make sense. The first group that we're going to look at is the anterior thoracoappendicular muscles. Anterior thoracoappendicular. Well, thoraco refers to the thorax. Appendicular refers, in this case, to the upper extremity. So think of muscles that come from the thorax and attach to the upper extremity. What bone creates that upper extremity here? Well, it's the humerus. The humerus is the upper extremity. So all these muscles will have some attachments on the thorax, the rib cage, something to do with this area that we call the thorax, and then they'll have some attachment on the humerus. So will these muscles be intrinsic or extrinsic to the glenohumeral joint? Will they be intrinsic or extrinsic to the glenohumeral joint? And why? Well, they're extrinsic. They're extrinsic. How do we know that? Well, the glenohumeral joint, the glenoid, is part of the scapula. The humerus is the humerus. And if it's an intrinsic muscle, both origins or both attachments would have to be within those two bones, the scapula and the humerus. Here we have an attachment on the humerus, but the other attachment for the pectoralis major is going to be the clavicle and the sternum. Clavicle and the sternum. There's no scapula involved. Hence, this is an extrinsic muscle. Remember, we talked a little bit about intrinsic and extrinsic muscles earlier. So the pec major is going to be the first muscle we're going to look at. And we can see it here on a couple of, you can see it on my great-grandpa. Here you can see the pec. It's this most superficial muscle. And notice that it's got two parts. And you can actually see the delineation line here. It's actually going to have this clavicular attachment. And you can, here's this fascial segment that separates the clavicular part up here from the sternal part down here. And both parts, however, will come across and they will run across the biceps, over the top of the biceps, and insert just on this lateral part of the intertubercular groove. So they'll run across over to here. And you also saw the pecs in the lab. So we had the sternal part, clavicular part. Notice that the nerve to them is pretty easy in that it's the pectoral nerve, but note that there's two parts, a lateral part and a medial part. The lateral part takes care of this clavicular part of the muscle, and the medial pectoral nerve innervates the sternal part. Notice that even with the sternal part, there's parts of these come off the superior 6 costal cartilages. So it inserts on the sternum and part of these cartilages in this area. And that's innervated by the medial pectoral nerve. Medial pectoral. Lateral pectoral nerve is off the clavicle up there. Main function is the pec major will adduct, bring the humerus closer to the midline, and will also help medially rotate. It will take that lateral side and roll it medially. Take the lateral side and roll it medially. It will tend to indirectly draw the scapula anterior. If you have a real tight pec, it'll pull both humeruses forward, which will also then draw the scapulas anterior. Hey, it's you and me together. If the humeruses are going to move, the scapulas are going to move with it. Let's see. Yeah, so functionally, we see this muscle probably, we can see it used maybe the most or in the bench press, lying on your back, weight in this fashion here. You contract your pecs, and it will adduct your humerus. Pull your humerus forward. Contract it, pull it forward. Hey, what motion does it control? Remember, controlling is going to be an eccentric activity. Well, when I lower the weight, what's my humerus doing? It's in this position. I lower the weight. The humerus is abducting. It's in that horizontal extension or horizontal abduction movement. And the pec helps lower the weight now. So when it eccentrically acts, it's also helping lower the weight. When it concentrically acts and shortens, it helps lift the weight. So here's the thing. If you would if you wanted to get stronger pecs, what you'd really do would be see how much weight you can lower. Now you need some spotters, but you need to see how much weight you can lower, because that fires more fibers of the pec, hence would get the pec stronger. But we don't have any competitions that say how much weight can you lower. but lowering the weight, even though it's an eccentric activity, that will have crossover to the concentric component, because you'll be making that muscle stronger, and then so when you eventually use it concentrically, it will have more strength to pull on to then work concentrically. So we have the pec major. Another one of these muscles that comes off the thorax and inserts on the appendicular area is the pec minor. The pec minor. Now this is a little bit unique. The pec minor, here we can see the pec minor right here coming off of ribs 3, 4, and 5. Now it really doesn't go over to the humerus though, so this is kind of a misnomer, but I didn't write the book. But it comes off the thorax and attaches up here on the coracoid process. Coracoid process. Since it comes off the cartilage in the thorax area, it's also going to be the medial pectoral nerve, just like the medial pectoral nerve innervated this thorax component of the pec major. And what it does is most times it stabilizes the scapula, and it does stabilize the scapula. But really, where is the pull of this muscle on the scapula? Well, the pull is to bring the scapula forward anteriorly. Well, here's the problem with this muscle and how it works. If you have poor posture and you have this forward shoulder position, what happens is your pec will kind of shorten to accommodate that, and it will get tight. And so it will help you maintain this poor posture position. So when you try to pull your scapulas back, and we'll see later that the rhomboids help pull the scapulas back, these pec minors are going to be fighting that all the time. So sometimes before you work on getting your scapulas back in the right position, you have to do some stretching of the pec minor, some stretching of the pec minor. And I'll tell you that type of stretching isn't the most fun, but it will help you maintain good posture. Next muscle, subclavius. Not going to talk about this too much. Just note that the subclavius attaches to the first rib, and it just helps keeps the clavicle in a more stable position by attaching it to the thorax and the first rib. Don't have to know the nerve of it. That's all you need to know. The last muscle in this area is called the serratus anterior. And you remember seeing the serratus anterior. Here you can see the serrated edges of the serratus coming off of ribs 1 through 8, or attaching onto 1 through 8. Now to find the other side, the insertion, we could say, is on the medial scapular border. So I don't think I have a good picture of the medial scapular border here. I don't think I have that. Oh boy. But picture the scapula facing you, and this will go around the back and be right on that medial border. So what happens is that the thorax is generally the stable area. That's why it's actually the origin in this case. Very rarely will the thorax get pulled back to the scapula. But so when these muscles contract, or this muscle contracts, they shorten, and they will pull that medial border around the ribs and forward. So it's going to protract that scapula. Protract. And then also you should know is that these lower fibers of the serratus, the lower ones, are actually stronger or have a different mechanical advantage than the uppers. So the lower ones, which attach lower to the inferior angle of that scapula, when these contract, they're going to pull that inferior angle up. And when they pull the inferior angle up, that will also pull this glenoid fossa up and make the glenoid fossa face more up as well. So when you bring your shoulder up, to have it work great, the serratus anterior will also be working, because it's going to bring the inferior angle of the scapula up, which brings the glenoid fossa up as well. So when we say it protracts and rotates the scapula, it actually rotates the inferior angle up, which rotates the glenoid fossa also up on that same side. Hope that makes sense. Now also here I've got winged scapula written down, winged scapula. So what I've done, and maybe some of you know what a winged scapula is, but I've added a picture onto my handout here. So this is back on page 5 of your handout. This is where I've got this picture. But here's an example of a winged scapula right here on this right side here. What he's doing is he's currently internally rotating and flexing his elbow. And notice how the medial border, this is the medial border of the scapula, is almost perpendicular to his back. It's almost perpendicular. Well, this happens when the serratus anterior is weak. And for example, if it's weak, if it's not weak, this, as the person does this medial border would stay right along the rib cage. It would stay flat like this other side is. But in this case, the medial border wings out, wings out. And this is called a winged scapula. And a lot of folks have this. And it can be bilateral or unilateral. It can be due to weakness. You just don't use the muscle. Hence, when you rotate the humerus, the scapula goes with the humerus as it's being rotated. The other reason why this can happen is it can be damage to the long thoracic nerve, the long thoracic nerve. And I'm going to go down to take a look at the brachial plexus here. And back here, we can see the long thoracic nerve. So here's the long thoracic nerve, and it's pointing to this nerve here that comes off, runs off of all these little aspects. Well, that long thoracic nerve goes to the serratus anterior. This nerve can be damaged at birth, maybe when the doc is pulling on the baby and it's grabbing the arm to pull the baby out. This nerve can be damaged, and hence it can cause a paralysis of this serratus anterior muscle. Earlier I showed you the medial and lateral pectoral nerve. Well, here is the lateral pectoral nerve, and here's the medial pectoral nerve. You won't have to identify these nerves on the brachial plexus for this class, but I can guarantee if you go on into PT, med school, and other areas, graduate work, you may have to know these other nerves that are associated with the brachial plexus. So that's, I'm going to try to fix up my outline here a minute too. Yeah, that looks a little bit better. So those muscles are anterior thoracoappendicular. Pec major and pec minor, subclavius, and serratus anterior. Now we're going to take a look at some of the posterior thoracoappendicular and scapulohumeral muscles. Still extrinsic. They're still extrinsic because they've got that thorax and appendicular component to it. First one is going to be the trapezius, and we're going to just know that there's 3 parts to the trapezius. Here the trapezius is still intact, and we have an upper trap. You can tell by the fibers. See how the fibers are going up, going up. We have a middle trap. Middle trap is right here, and it's where the fibers are most horizontal. Then we have a lower trap. Lower trap is down here. Notice that they all have attachments on the spine and then on the spine of the scapula. Different parts will pull the scapula in different directions. This part here will pull the scapula up. This part here will pull the scapula down. This part here will help retract the scapula. Hope that all makes sense. they're all innervated by cranial nerve 11. Cranial nerve 11. While the book says it stabilizes the scapula, I will tell you it certainly does that. But again, what's probably more important is when the scapula has to move. So as we said, the superior part will pull the scapula up. The middle part will pull the scapula medially or retract the scapula. And the inferior aspect will pull the scapula down. Again, hopefully that will make good sense to you. And again, know that it's innervated by the 11th cranial nerve. Okay, let's see what else we have here. The latissimus dorsi. Yes, latissimus dorsi. Large muscle on both sides. Latissimus dorsi. Dorsal and lateral. Dorsal and lateral. Coming off part of the spine, and then coming off some of the fascia that's down below here. It's going to run up and under the arm, and then it's going to run, as it runs under the arm, it's going to come up over in the front of the humerus, and it's going to insert in the base of that intertubercular groove. Intertubercular groove. Let's see here. Do I have a picture of the intertubercular groove? Yes, here it is. So this is the right humerus. Here's the head. So the latissimus dorsi will come under the armpit, which would be right here, and then come and insert and rest right in the base or in the groove part of that intertubercular groove. We also said that the pec major came over the top of this area, came over the top of all the muscles that we'll see later that the long head of the biceps actually runs in this groove. The pectoralis major comes off over the top of all that and inserts on the lateral part of the groove. This lat comes in and attaches medially, forms a little bit of the floor of this groove, and then we'll see later that the long head of the biceps runs right up through that intertubercular groove. Sometimes it's called the bicipital groove because it also holds onto that, or it forms a place of rest for the long head of the biceps. So the latissimus dorsi is what we're talking about here. Huge muscle. Swimmers, there's a number of swimmers in class, and I think I've asked them at times before, and it's maybe used 10,000 times. For every stroke, that lat will be used. And so it's not uncommon when the swimmers are doing two-a-days to have over 10,000 contractions of that lat. And hence that lat also, as it builds up, gives the V-shaped to the swimmer. It's this lat muscle hypertrophies. Pretty darn amazing muscle. Latissimus dorsi. So what does it do? Well, for sure, it adducts the humerus. Adducts. If I bring my arm up, that's going to put the lat on stretch, and then the lat will contract and bring it down. Adduct. Also extend, bring the arm back. And because it's in here, because it comes up under the armpit and inserts here, it also works to internally rotate. And that's what that swimmer's doing too. They're pulling their arm down and they're internally rotating in most cases, with maybe the exception of the backstroke, I guess. So that is the latissimus dorsi, the thoracodorsal nerve. Thoracodorsal. So dorsal is back of the thorax, and this muscle is back of the thorax. Dorsal aspect is the back of the thorax. Next muscle is going to be part of the deep posterior group. So deep means we're going to take off this trap and see what we find when we take this trap off. Well, boom, here we have the rhomboid major, this inferior group, and right up here is the rhomboid minor. the rhomboid minor. But before that, we should talk about the levator scapula. Yep, levator scapula. And here we can see the levator scapula. Levator scapula comes off of this upper medial border of the scapula. Here's the medial border of the scapula. Comes off that upper medial border, and it goes up to the transverse process of 1 and 4, C1 and 4. Here you can see it running under the splenius muscle. This is the splenius. Levator scap runs underneath it. Dorsal scapular nerve here again. Dorsal scapular nerve. So it's on the dorsal side of the scapula. Dorsal scapular nerve. And what does it do? Well, yeah, this name tells you what it does. It elevates the scapula. Elevates the scapula. But hey, if it elevates the scapula just from here, what's going to happen to this glenoid fossa? Well, this whole complex here won't go up evenly, but when this part here is elevated, this glenoid fossa will be depressed, or it will start to face down more. So it will face or tilt the glenoid inferiorly as that muscle is contracted. Levator scapula. Levator scapula. All right. Getting a picture how that works. So in this group so far, we've looked at the traps. Traps have 3 components that work on the scapula. And if the scapula is moving, that's certainly going to affect the glenohumeral joint. And then we have the lats. Now the lats they do not have a true attachment on the scapula, but they run over the inferior angle right here. You can see they run over the inferior angle. So they'll have some role in how this scapula moves as well. And then we have some smaller muscles deep to these larger muscles. They are the levator scapula that we just saw. And now we're going to take a closer look at the rhomboids, shaped like a rhombus, the rhomboids. Rhomboid major is larger, and it's inferior to the minor. It's inferior to the minor. Its main action would be to retract or pull this medial border closer to the spine of the to the spine. So that's called retraction. Again, you can see by the angle of pull, though, as this gets pulled kind of up this way, that means that this side, this glenoid, will also tilt inferiorly. It will tilt inferiorly. So it's going to complement some of the motions of the levator scapula. It's going to complement some of those motions of the levator scapula. And again, like the levator scapula, it's on the dorsal side of the scapula. So it's going to be the dorsal scapular nerve. Dorsal scapular nerve. All right, doing okay with this? Yeah, it's going to be the muscle day. It's going to be the muscle day. Well, I think, though, that those are probably the toughest muscles that we're going to be looking at today. We're now going to go intrinsic to the shoulder. We're going to go intrinsic to the shoulder. So those muscles will be the muscles that have an attachment on what 2 bones, if they're intrinsic? What 2 bones? Molly? Molly, are you there today? What 2 bones? Right, scapula and humerus. Scapula and humerus. So, okay, let's take a look at them. All right, one of the biggest muscles that we're going to see is going to be the deltoid. The deltoid. And unfortunately, cannot see the deltoid on either one of these pictures. But we can see part of the deltoid right here. This would be the anterior deltoid coming off the clavicle. and part of the acromion process. And then in the back, it would come off the spine of the scapula and the acromion process. The deltoid has three parts: an anterior part, a medial part, and a posterior part that we can't see here. And the deltoid, it comes down and inserts on the humerus, the deltoid tuberosity, which is right at the base of your deltoid. If you follow your deltoid down, you'll see kind of where it ends. There's a little kind of bump right there in your humerus, and that's the deltoid tuberosity. So this muscle is innervated by the axillary nerve, and we will certainly study that axillary nerve more when we look at the brachial plexus. The axillary nerve is right down here. Axillary refers to the axilla or the armpit, and it actually goes into the armpit and then up into the deltoid, into the armpit, and then comes up and innervates the deltoid up above it. The movements of the deltoid: anteriorly flexes and medially rotates. So this anterior part will flex and medially rotate. The middle part abducts the arm. That should make sense. And the posterior part extends and laterally rotates. So there's three parts to this deltoid. In fact, deltoid, or delta, is a Greek letter that refers to what? Yeah, the triangle. So in this deltoid muscle, there's an upper part of the triangle. The base of the triangle would be along the top, and then it narrows down where it inserts on that deltoid tuberosity, the deltoid muscle. And based on this, where it's located should give you a great hint into what the actions are. Again, the anterior part is going to be in front, so it will flex. Posterior part will do the opposite, extend. Mid part abducts. Another intrinsic muscle is the teres major, And I can show you the teres major on this model here. So the teres major is this muscle right here. Hoping you're seeing this arrow that I'm moving back and forth. This is the teres major. And the teres major comes off of the inferior scapular angle. So here's the scapula, inferior angle. Down here is the teres major. And it's going to follow, here's the lat below it, it's going to follow the lat and go under the arm. It's going to go under the arm, and it's going to insert on the medial lip of that intertubercular groove, the medial lip of the intertubercular groove, very close to where that lat also inserted. So it's going to have similar activities as what the lat does. And so let's see here. Yep, adducts and medially rotates the humerus. So the teres major is a kind of an assister to the lat. It assists what the lat is doing. Lower subscapular nerve. Hey, you know what? I'm not going to be concerned about you knowing this nerve. I'm not going to ask you this nerve. Just know the action of this muscle. Okay? Intrinsic muscles. All right. Now we're going to look at four muscles, and these four muscles are known as the rotator cuff, the famous rotator cuff muscle group. And just to keep you with us here, keep you with me, we're going to look at these muscles, answer these questions, and then we're going to call it a day. Monday, we'll finish up the muscles of the arm and the rest of this handout, okay? We're going to finish up the rest of this and the muscles of the arm with the brachial plexus, looking at it again on Monday. So hang here, hang tough. So the rotator cuff muscles are intrinsic and deep. And their names will tell you a lot about where they're located. So let's take a look at, let's see if I go back up, even give you a different perspective. Yeah, right here. So here again, we can see the rotator cuff muscles from the posterior view. We've taken the traps off, taken the deltoid off. So, and just to give you a landmark, here's the spine of the scapula. See where I'm moving this arrow? Spine of the scapula. So on top of the spine of the scapula, there was a landmark called the supraspinous fossa. Supraspinous fossa. So guess which muscle is going to be in the supraspinous fossa? The supraspinatus muscle. Supraspinatus muscle. So bringing you back down, look at it. Here's the supraspinatus muscle. Here's a picture of it close up. Here's that spine of the scapula. So it originates in that supraspinous fossa, and it runs over the top and runs over the top of the fossa, but under, see how it's under this acromion process, where that acromion process sticks out. Here you can see the acromion process. Here that supraspinatus muscle runs. And it's going to run under these ligaments, and it's going to insert on the greater tuberosity here of the humerus. Here's the greater tuberosity of the humerus. Inserts there. It initiates abduction, so it's going to initiate abduction, and it's going to have some other important roles, particularly of holding the head of the humerus in against the glenoid fossa. Because think about this. If this muscle contracted, if it got shorter, it doesn't have a great angle of pull to help abduct it, but what it does do, it has a great angle to pull the head of the humerus into that glenoid fossa. So this muscle will help provide stability to the head of the humerus when it contracts. A couple other muscles here in the rotator cuff. One is the infraspinatus, So these three components here are all the infraspinatus. Infra meaning below the spine. So the infraspinatus is in the infraspinous fossa, and it too will come over and insert on the greater tuberosity. Both of these muscles are innervated by the suprascapular nerves, however. The suprascapular nerve innervates both of these muscles. The next muscle here, and what does it do? I'm sorry. It laterally rotates. Here it's coming along the back of the scapula, hitting on the lateral side of the humerus. And by doing that, it's going to cause lateral rotation. But also it's going to help pull the head of the humerus in. So it's going to help provide stability as well. Next muscle, teres minor. And here's the teres minor. The teres minor is just inferior to the infraspinatus. And if we go back up here, here's the teres minor right here. Teres minor, see this? I don't know if you can see this movement here. Teres minor is right here, just below the infraspinatus. But then remember we said this muscle down here is the teres major. So the teres minor is superior to the teres major. Teres minor, smaller, hence the word minor, is superior though to the teres major. Similar over here, we have the rhomboid minor, smaller, but superior to the rhomboid major. So teres actually means round, so it's kind of a round, long muscle. Here's a round, long muscle, but this muscle's bigger in its diameter than this one. Hence teres major, here's teres minor. And again, look where it attaches, just at the lower part of the greater tuberosity of the humerus. It's going to do the same thing that the infraspinatus does. It's going to help laterally rotate, and along with helping laterally rotate, it will help hold the head of the humerus in. And notice that this will also kind of help hold the head of the humerus down. And even these fibers here on the infraspinatus will help hold that head of the humerus down in that glenoid fossa. Down. That's going to be important to note. Last muscle of the rotator cuff is the subscapularis. The subscapularis. And the subscapularis is on the anterior surface. Remember, this is the posterior view of the scapula. Now, if we look at this, this is the right scapula. If we look at the right anterior view, here's what we'll see. We'll see the fossa that forms the subscapular fossa. Subscapular fossa is right here. And this subscapular fossa holds the entire subscapular muscle. Subscapular muscle. Okay? Hope this is making sense to you here. Now this subscapular muscle comes across and inserts here on the lesser tuberosity or lesser tubercle of the humerus. It's on the medial side, anteriorly, so this will help medially rotate. All these other muscles back here, or at least the infraspinatus and the teres minor, help laterally rotate. The subscapularis, along with the teres major and the latissimus dorsi, help medially or internally rotate the humerus. It will also help adduct the humerus, and because it's pulling down this way, and also it's going to help hold the head of the humerus in. Hold the head of the humerus in. Okay, excuse me just for 1 minute. All right. Got a call from Carol here. She's in lab right now talking to you guys, but I need to get through just a little bit more. Now, you know what I'm going to do? I'm going to let this sit with you, but I want you to stay with these muscles. I want to just mention a couple of little things, and we'll talk about how the rotator cuff works. We'll talk about that on Monday as well. But I want to show you the coracoacromial arch. The coracoacromial arch is simply this area between the acromion process back here and the coracoid process, and these ligaments, the coracoacromial ligaments. See that it forms an arch. And what runs under the arch? What runs under the arch? Oh yeah, the supraspinatus tendon. That runs under the arch. There's a term called shoulder impingement, and shoulder impingement occurs when the supraspinatus tendon gets pinched between the head of the humerus and this arch. Now we said that these muscles here, the supraspinatus, infraspinatus, teres minor, and subscapularis, are often known as the rotator cuff. And rotator cuff tears are very common, unfortunately, particularly in baseball pictures and in oldsters later too. And I'll discuss more of that on Monday. But one of the main reasons why that they get tears is because this supraspinatus tendon gets impinged and gets a bad blood flow and eventually tears from excessive use. We'll talk more about that on Monday. All right, scholars, that's it for the day. Thanks for hanging in there. I'm going to give you an assignment for Friday. You're going to meet as teams again. But get to know these muscles. That'll be part of your assignment on Friday when you get together. You need to know these muscles and how they work. We're going to talk about how the rotator cuff works on Monday, about the biceps and triceps muscles, how they work on the humerus, and then also review some material from the brachial plexus. All right, fire up, gang. Thanks for hanging with me. Love you guys, you knuckleheads. Now, unless Eric's got some words for you, and he should because he's a wise man. Pressure's on, Eric. Anyway, you guys fire up and have a great day. See ya.